And the first speaker is Edouard Callebout. He's a young digestive oncologist working in UZ Gent, who specifically focuses on the treatment of esophageal and gastric cancers. So he will talk you through what we need to know when you suspect a malignant lesion in the upper GI region. Thank you. Edouard?
Thank you for the introduction, Karen. So we found a esophageal tumor. What should we do? That's the questions. I have no disclosure. First, a little slide about the anatomy of the upper GI tract. The esophagus starts at the lower cricoid cartilage, and there we call it the cervical esophagus, and it extends to the stomach, where the first region that we encounter is the cardia. There you have the gastroesophageal junction, which is important because a lot of tumors arise in that region, and when you see a tumor there, you have to talk about it using the Sievert classification. You have 3 types of Sievert, the types 1 and 2 that have to be staged as esophageal cancer, and the type Sievert 3 has to be staged as a stomach cancer. What is a Sievert 3 adenocarcinoma? It is a tumor where the epicenter is more than 2 centimeters distal from the GI junction, even if the GI junction is involved. So there are 2 types of esophageal cancer with different etiologies. You have the adenocarcinoma, which is most prevalent in Western countries, and its incidence is rising. Risk factors are GERD, which leads to Barrett, where the squamous epithelia changes into columnar epithelia. Another risk factor is a high BMI. These tumors are found distally in the distal third of the esophagus and at the junction. Then you have the squamous cell carcinoma, which is more prevalent in Asian countries and in Africa, which is less prevalent over here. When we encounter it in Western countries, it is often associated with smoking and alcohol consumption. These tumors are found more proximally in the upper or middle third of the esophagus. So everybody knows how to do the diagnosis. When you have complaints that are suggestive, you do an endoscopy and you take biopsies. It is important to take enough biopsies, 6 to 8 biopsies, but then it is not finished for the endoscopy. It is very important to describe the location of the tumor relative to the teeth, but also to the GI junction. And why that is because of the Sievert classification, we already told it. Then it is important to describe the length of the tumor, the extent of circumferential involvement, and if there is any degree of obstruction. If there is a Barrett esophagus, you should describe it according to the PRA criteria.
You can see that on top, the red and brown the blocks, very low number of patients have a stage 3 and 4 cancers, while cancers in the middle not detected via the screening programs, almost 40% are stage 3 and 4. And I don't have to convince you and to tell you that patients with the detection, with the diagnosis in the setting of the screening programs have a better outcome, a better prognosis compared to patients in the middle who were diagnosed in the setting of just symptoms and not participation to a screening program in this situation. So that's crucial to work further on that. Another aspect that I touched upon already is that we need to know information on whether the tumor is in the setting or of a hereditary colorectal cancer syndrome. That has implications for the endoscopist. We know that more advanced imaging, especially in patients with Lynch syndromes, may improve the detection of early lesions in this setting. So an endoscopist should have a clear knowledge also on important aspects on the potential of some of the hereditary syndromes. And you see here a complete list of some of the hereditary syndromes with some of the genetic alterations that are linked to that. And indeed, in colorectal cancer, around 20-25% of patients have either a familial predisposition, either a hereditary predisposition. In the most frequent syndrome is the Lynch syndrome, but we have also FAP syndrome, we have hamartomatosis polyposis syndrome, and some other rare syndromes in this setting where we are doing more and more multi-gene panel testing, looking for germline alterations and germline mutations, and also some rare, more rare mutations such as CHEK2, PALB mutations, but also the more frequent mutations such as BRCA. As an endoscopist, we are confronted also with screening and a request to do screening in some of these patients with some of these hereditary predispositions, and that's important in this situation. As is outlined also on this scheme, where we may have some of the genetic predisposition to colorectal cancer in the setting of some of the polyposis syndromes, but also in some of the non-polyposis syndromes, such as mismatch repair deficient syndromes or proficient syndromes, including Lynch syndrome, but some of the other mutations, such as POLE and POLD mutations, just to give you a snapshot of the fast-moving knowledge also in this setting. This is another image I wanted to share, where the endoscopist may play a crucial role. This is a patient who underwent chemoradiotherapy for a rectal cancer with the aim and the goal to go for a watch and wait strategy in this situation where endoscopic, thorough and in-depth endoscopic evaluation and correlation with MRI, with nuclear medicine, with MRI diffusion-weighted imaging is crucial in order to come up with a decision: do we maintain a watch and wait attitude in this patient with an organ saving strategy, or do we go for total mesorectal excision or other rectum cancer surgery options for these patients? And finally, it is important that the endoscopist is also aware of the increasing number of cellular targets, an increasing number of anti-tumor agents. Adequate biopsies are often requested by the GI oncologist, sometimes new biopsies, and in the future we may go for liquid biopsies looking at circulating DNA, or we may go for repeat biopsies in the tumors in order to understand more some aspects on the changing aspects under pressure of targeted agents, understand better tumor heterogeneity, and we may also correlate biopsies in the primary tumor and in the metastasis, and we may go even for single cell analysis in the future, as we're doing now in Leuven, some research projects also in this situation. Because also in patients with metastatic disease, this may further contribute to the better outcome of patients in this situation. Indeed, in patients with metastatic disease, with an improved outcome, with an improved selection of patients, with an improved adequate personalized use of the different agents, we are also further improving the outcome, not only in early disease, but also here on this example with these different agents and in-depth molecular analysis in patients with metastatic disease. So the endoscopist is an important player in the multidisciplinary team, in the multimodal approach of patients in the management of early cancers, but also increasingly in patients with advanced disease in the modern management of colorectal cancer. Thank you for your attention.